On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Antibiotic Stewardship Webinar Series, Antimicrobial Baseline Data. My name is Joanne Atkins, and I will be your moderator for this program. We welcome any comments or questions. All materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar. Amanda Bennett is an infection prevention advisor for the Patient Safety Authority. In this role, she serves as a resource for Pennsylvania facilities through education and the development and monitoring of infection prevention and reduction initiatives. Amanda has an extensive background in infection prevention, laboratory testing, analysis and interpretation of diagnostic results, education, and regulatory standards. Prior to joining PSA, Amanda worked in acute care settings as a molecular pathology medical laboratory scientist, point of care coordinator, and infection preventionist. Amanda, I will now turn the program over to you.
Thank you, Joanne. I'd like to welcome everyone and thank you for your time today. We will be talking about antimicrobial baseline data, and this is our 6th webinar in the Antibiotic Stewardship Series. The objectives for today's webinar are to outline commonly overused drugs and the harms incurred by residents, discuss different antibiotic use measures, and identify baseline infection rate data related to antibiotic use. We've talked about the overuse of antibiotics in this webinar series, and we know there is a lot of research to show antibiotics are overused. In this webinar, we will focus on the data we can track as part of an antimicrobial stewardship program and how to use that data to keep our program moving forward. An article from 2015 detailed that the 5 most overprescribed drugs are azithromycin, amoxicillin, cephalexin, trimethoprim sulfamethoxazole, and ciprofloxacin. These are overprescribed for a variety of reasons, including viral infections, which obviously don't need an antibiotic, skin conditions, urinary tract infections, especially in the elderly, skin boils, and when a more simple antibiotic could have been used instead. Data pulled from the PA PACERS database in 2014 shows that the most prescribed antibiotics in Pennsylvania's long-term care facilities were fluoroquinolones, cephalosporins, the other category, which consisted of other antibiotics, antivirals, or antiparasitics, trimethoprim sulfamethoxazole, and penicillins. While they're not in the same order as the list we see on the screen, this does closely match the most overprescribed antibiotics. So what does this mean for residents? It increases their risk for serious diarrheal infections such as C. diff, increases the chance for adverse drug events and drug interactions, and can create colonization and infection with antibiotic-resistant organisms. These next 2 slides I know aren't the most interesting, but it is important that we get some terminology out of the way before we continue on to the meat of this presentation. First is a measure. This is a valid and reliable indicator that can be used to monitor and evaluate the quality of important governance, management, clinical, and support functions that affect patient outcomes. We can describe a measure by its validity. Valid is the extent to which a measure accurately reflects the concept or construct that it is intended to measure. And we want a measure to be reliable, which is the ability of the indicator to accurately and consistently identify the events it was designed to identify across multiple healthcare settings. And we have different types of measures. First is a performance measure, which is a quantitative tool that provides an indication of an organization's performance in relation to a specified process or outcome. And then we have clinical measures, which are a subset of performance measures designed to evaluate the process or outcomes of care associated with the delivery of clinical services. These allow for intra and inter-organizational comparisons to be used to continuously improve patient health outcomes, and they focus on the appropriateness of clinical decision-making and the implementation of these decisions. Clinical measures must be condition-specific, procedure-specific, or address important functions of patient care. When collecting data and performing subsequent calculations, it is important to think about what measures you want to focus on as a part of your program. When doing this, there are some key matters to consider. Two things to consider are external and internal requirements. External requirements include federal and state regulations, accreditation, payer and purchaser expectations, and areas known to be of interest to the residents served. Internal requirements are services that need improvement, concerns of the medical staff, and then any high risk or high volume clinical care areas. The measures also need to have clear-cut definitions, be readily applicable in the healthcare setting, be clinically important, provide precise and usable information, and be supported by prior studies. And there are different ways to calculate these performance measures. We can use a rate, a continuous variable, or a ratio. When calculating a rate, the numerator is the event that's being measured, divided by the denominator, which is the population at risk. We then multiply this by whatever your selected multiplier is, which is usually 100 or 1,000, depending on what it is that you're calculating. The second way to calculate a performance measure is with a continuous variable. This is used when many results are possible, such as days of treatment or length of time to treatment start. An average or a mean can then be calculated using all the various results. And last, we have a ratio, which is a calculation method which depends on the relationship between two counted sets of data, and it will always have a value between 0 or greater. With a ratio, the number does not necessarily have to be a subset of the denominator. When considering performance measures, it's important to understand what data is necessary to track. Essential elements include a resident identifier, when the antibiotic was prescribed or administered, which will allow comparing antibiotic use over time, the antibiotic name and class, which helps evaluate prescribing practices, days of therapy or days dispensed, as this quantifies antibiotic use over time and allows for comparisons, the route of administration, such as oral or intravenous, and residence days, which is needed to calculate your rates of antibiotic use. These should all be readily available from the medical record or pharmacy, and these elements can be used to quantify and track antibiotic use within the facility over time and help identify opportunities for improvement. Other important elements to consider tracking are the indication or the reason the antibiotic was prescribed, the duration of the antibiotic course, the unit where the resident is located, the admission date, and the name of the clinician who prescribed the antibiotic. These elements aid in identifying the reasons behind inappropriate antibiotic prescribing and should be tracked based on the needs of the facility. The CDC's core elements of antibiotic stewardship for nursing homes describes 3 types of measures used to guide practice changes and track the impact of new interventions. First are process measures, which track how and why antibiotics are prescribed. When done over time, process measures can show whether policies around antibiotic prescribing are being followed by staff and clinicians. Examples of this can include reviewing medical records, looking for new antibiotic starts to determine clinical assessment, prescription documentation, and selection of antibiotics to determine if these were all in line with the facility's antibiotic use policies. Antibiotic use measures track how often and how many antibiotics are prescribed. This is used to review patterns in antibiotic use and measure the impact of new stewardship initiatives. Depending on the selected measure, you will either see a snapshot of information, like with prevalence surveys, or data over time, as with antibiotic starts and days of therapy. You'll select which measure you want to track based on the type of practice intervention being put into place. And then there's antibiotic outcome measures, which track the adverse outcomes and costs of antibiotics. These will monitor different clinical outcomes like C. difficile infections, antibiotic-resistant organisms, or adverse drug events. These are then used to determine if antibiotic stewardship activities are improving resident outcomes. For this presentation, we're going to focus on the first two, process measures and antibiotic use measures. Tracking process measures is an important part of an antibiotic stewardship program because it is assumed that if a process is working, meaning that it is being well executed, that we will increase the probability of achieving our desired outcome. Furthermore, process measures are useful for evaluating quality if we can link them to an outcome measure. For example, if we are tracking the completeness of an assessment documentation, which is our process measure, then we can link that to appropriately prescribed antibiotics according to facility policies. Process measures focus on the actual process of our initiative, not the outcome we're hoping to achieve. This is an important step because if our interventions aren't successful, then we need to evaluate where in the process it's falling short. Some examples of process measures include completeness of clinical assessment, completeness of antibiotic prescribing, documentation, and antibiotic to indication consistency. When checking a clinical assessment, it's important to evaluate the resident's clinical status, physical exam, and laboratory results at the time when a potential infection was being considered. Without complete information, it may be difficult to determine the rationale for appropriateness of the antibiotic. If your facility has a protocol or algorithm that is to be used when evaluating a resident for infection, a chart audit to ensure this is followed is an effective way to track this process measure. Another auditing method is to assess the completeness of antibiotic prescribing documentation. This can be done for both antibiotics ordered in the long-term care facility and also those that are initiated from the transferring facility. When evaluating this documentation, it's important to check for the dose, the route of administration, the duration, which should include the start date, the end date, and the planned days of therapy. And then last, the indication, which should consist of the rationale for prescribing and the treatment site. A third type of process measure is assessing the consistency of antibiotic selection with recommended agents for the specific indication. With facility-developed treatment guidelines, intermittent review should be done to ensure antibiotic selection follows the facility's policies. So overall, why do we care about these process measures? We already know that it's an important part of validating that there is compliance with all parts of an initiative or process, but process measures can also monitor variations that may be occurring in these processes. They can be used when the outcome we're looking for is rare or difficult to measure, or if there is difficulty in acquiring data, because both of these factors make monitoring outcome measures more difficult. Additionally, process measures are useful when evaluating how effective education has been by measuring behavior or tracking compliance with basic infection prevention practices such as hand hygiene. Moving on, the other type of measure we'll be discussing is measures of antibiotic use, which tracks how often and how many antibiotics are prescribed. Examples of this are point prevalence of antibiotic use, antibiotic starts, and antibiotic days of therapy, or DOT. Point prevalence of antibiotic use tracks the proportion of residents that are receiving antibiotics at any given time. This can be measured in a single day or a week or a month, essentially any time period that's useful to your facility. Point prevalence surveys can be an easier way to see antibiotic use data because it is time limited. With this method, you get a snapshot look at the burden of antibiotics in a facility, along with information specific to the residents who are receiving the antibiotics and why they are getting them. A benefit to this method is that a broader range of antibiotics can be captured by including both antibiotics prescribed in the long-term care facility and those that are prescribed prior to the resident's admission. This captures the true total burden of antibiotics at the facility and those at risk for complications. In contrast to the benefits, it's important to also recognize the limitations. Since we are only looking at a snapshot of information, point prevalence does not necessarily give a full picture of antibiotic use over time. For example, there was a review in 2014 which summarized studies exploring antibiotic use and prescribing patterns. In this review, it was shown that a single-day prevalence may show that only 5 to 13% of residents are receiving an antibiotic. But when we looked at a study that followed residents over a long period of time, such as a full year, it shows that 50 to 75% of residents received one or more courses of antibiotics. To calculate the percent of residents receiving antibiotics, you would take the number of residents on an antibiotic divided by the total residents in the facility and multiply it by 100. This can be further stratified to a more specific resident population, such as the percent of residents receiving antibiotics that are in a short stay unit or a long stay unit. And then another calculation is the percent of new admissions receiving antibiotics. For this calculation, you take your number of residents admitted to the nursing home and on antibiotics, and you divide that by your total number of new admissions times 100. Our second measure of antibiotic use is antibiotic starts. This is something that most long-term care facilities already look at as part of normal infection prevention surveillance. In general, this is calculated based on antibiotics prescribed after admission to the facility. This calculation can be used to assess the impact of antibiotic stewardship initiatives, which were intended to educate or guide providers when antibiotics are not appropriate. But this calculation might not be helpful when initiatives are intended to decrease the total number of days of therapy. And to calculate this, we want to look at the number of new antibiotic prescriptions divided by the total residents and multiply that by 1,000. Antibiotic starts can also be calculated by indication, for example, new antibiotic starts for urinary tract infections or by individual prescribers. But it is important, if you're calculating for individual prescribers, to consider the total number of residents being cared for by each provider. And then our last calculation is antibiotic days of therapy. While tracking antibiotic DOTs takes more effort than antibiotic starts, it might be a better measure to observe changes in antibiotic use over time. DOT is also used to calculate the antibiotic utilization ratio, or the AUR. With this calculation, it's important to understand what is considered an antibiotic day. An antibiotic day is counted as each day that a resident receives a single antibiotic. So that means that if there's a resident that's given a 7-day course of one single antibiotic, we would count this as 7 antibiotic days. But if a resident is given a 7-day course of 2 antibiotics, we would need to count this as 14 antibiotic days. To then calculate the antibiotic DOT, you take the sum of all of these antibiotic days for all of your residents in the facility for your given time frame. You can do this for a month or a quarter. And then to calculate your antibiotic DOT, your total monthly DOT, this is your rate of antibiotic DOT. It's the total monthly DOT divided by the total monthly resident days times 1,000. And then your AOR is very similar, except you're not multiplying it by 1,000. It's just your total monthly DOT divided by your total monthly resident days. So now that we've gone through these different antibiotic use measures and how to calculate them, what do we use them for? First, we can identify reasons behind inappropriate prescribing and then design effective stewardship initiatives based on those. They can help define the specific resident populations where interventions can be the most useful. And finally, they can be used to provide individualized feedback around antibiotic prescribing practices to clinical providers. The next 2 slides are from Appendix C of the CDC's core elements of antibiotic stewardship for nursing homes. and they demonstrate ways to visually present data within a facility and how to interpret when you want to take a closer look and think about areas where there are opportunities for improvement. This bar chart is showing 2 years worth of DOT data per 1,000 resident days. Each year is separated into 4 quarters. Examining this figure, you'll notice the increased antibiotic prescribing rates in Q3 of 2017. This is more than twice the rate as the same time in 2016. So this would be an opportunity for the facility to determine what exactly was going on in Q3 of 2017 that we're seeing these increased rates. When looking at data over time, you not only want to look at the data to see if it fluctuates over time, but also compare similar times of year, year after year. This is because prescribing has cyclical patterns during the season. It wouldn't be unusual to see prescribing increase during the fall and the winter and see higher rates than during the summer and the spring. And that's why you want to look at prescribing rates in combination with doing chart audits to ensure that we aren't missing an additional increase in inappropriate prescribing, for example, during the winter when we may see prescribing antibiotics for viral infections, which isn't necessary. And this figure shows the percentage of antibiotics prescribed by class during a 3-month period. This helps to identify where the facility could target their chart reviews to make the largest impact. Reviews targeting the most prescribed antibiotic class can help determine the appropriateness of prescriptions. And now we have our first polling question here. So the first question is, how many antibiotic days would be counted for resident 2 during May? And so we want to make sure that we remember for antibiotic days, each day that we want to count is how many residents receive a single antibiotic. So you do need to be careful that if one resident is receiving more than one antibiotic during the time period, that you're making sure that you count all of those. Okay, we'll just go over the answer then. So for those of you who are selecting B7, that's the correct answer. And we're getting that because we're looking just at resident 2 during May. So you want to be careful not to also look at resident 2 during June. So resident 2 in May, you're seeing that they started the antibiotic on May 5th, and then they got that antibiotic for 7 days. And our next question. So this is, what is the DOT for June? And for this, we want to remember that the days of therapy are the sum of all antibiotic days for all residents in the facility during a given time frame. So we want to make sure that we are including all the residents during that specific time period, but we don't want to count days for those residents that were outside of our specific time period. And it looks like most people are answering C, 15, which is correct. And we are looking at just June, so you're going to add 3, 7, and the 5 all together, and that is where you get the 15. So that was great. Everybody seemed to be getting those answers. And so just to summarize this, I know that a lot of these tracking possibilities and calculations can feel a little overwhelming, but you don't have to go at this alone. This slide is a screenshot of a resource from the Minnesota Department of Health. In general, the Minnesota Department of Health is a really great resource with a lot of tools, so I do recommend that you check out their website. This particular tracking tool allows you to put in your data. On the top left, you have your raw antibiotic data. The top right is the number of each type of infection by month, and the bottom are specifics about each infection, the resident information, classification of the infection, the resident history, specifics of how the diagnosis was made. There are a lot of other categories here that you can input data on, but I wasn't able to fit them all onto a slide. And then what we have is this tool also then takes your data and generates these charts. And these are really great to allow the IP to see the data on a larger scale and see trends over time. And they can also be used for presenting to others within the facility. They would be really effective to use during an infection control committee meeting or an ASP meeting to help others understand what's happening at the facility. And then our last two slides here are screenshots from the checklist provided in the CDC's core elements of antibiotic stewardship, and they give some concrete next steps to assess the topics we've covered today. They can be used as a baseline assessment to see where your program currently stands and also track your progress along the way and determine next steps to continue improving and expanding your program. This slide covers policies and procedures that can be put into place to improve antibiotic use and prescribing, along with how the pharmacy can support the program. Then this next session is more specific to data and tracking. So it's covering what measures of antibiotic use and outcomes of antibiotic use are being monitored within the facility. And Joanne, I will now turn the program over to you.
Thanks, Amanda. That concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. If a resident starts on an antibiotic, but is later changed to a different antibiotic due to culture showing resistance to the first one ordered, is that considered one antibiotic start or two?
That is a very good question. I would consider that two antibiotic starts, but you do have two different reasons for it. It is technically two antibiotic starts, but you can look into your data and see that the one is because they were prescribed the antibiotic as a broad spectrum, and then we de-escalated based on the results, which is what should be happening with our antibiotic stewardship program if we're following our policies.
And we have another question that has come in. We are just starting to collect antibiotic stewardship data for the facility. Where should we begin?
So this is going to really depend on what your specific concerns are. A good one to start with would be antibiotic starts, because that is something that facilities usually are already tracking as part of your surveillance. I would talk this over within your ASP group and see what everyone considers to be your biggest concerns, and then let that drive where you want to start your tracking.
And Amanda, I do have another question. We present provider prescribing during the antibiotic stewardship portion of the infection control meeting, but what should our elevator message be to the providers? They don't seem to get why we are showing this information.
So that is a very good question. That's something that we've been discussing within the PSA as well. I think that what needs to be conveyed to the prescribers is exactly what the burden is of antibiotics on the facility, and then what that means to residents, what that means as far as outcomes, further complications. They really need to understand the specifics and the data and what this is doing within the facility. I think that will help grab their attention and understand what their role needs to be in moving your program forward.
Thanks, Amanda. And we are at time. I want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct inquiries to Shelley Mixel at shmixell@pa.gov. This concludes our webinar.